Hello, my name is Sam Feltham and welcome to Expert Interviews here on Smash the Fat. With me today is medical doctor, Dr. Jeffry Gerber, all the way from Denver, Colorado. How you doing, Jeff?
I'm doing great, Sam. Thanks so much for inviting me. I love everything that you're doing there in the UK.
Perfect. Thanks a lot, Jeff. It's much appreciated, and vice versa as well, because the reason that I wanted you to come on the show is that you run a great website, blog, an actual clinic at denversdietdoctor.com, and that's kind of the home for your actual practice itself, which is the South Suburban Medical Practice. Is that right?
Yeah, that's right, Sam. We're located in the South Metro Denver area, and I've been here since 1993. Actually started out in Philadelphia. That's where I trained, and just the mountains, the beautiful mountains, and the Colorado Rockies were calling to us. So we moved.
Absolutely. And as we were discussing before the show, I lived in Colorado for a couple of winters working at Winter Park, and I may have possibly tutored your kids in snowboarding. So it's quite a small world.
Yeah, very small world. I remember that British guy. It must have been you back then.
Undoubtedly. Cool. So the reason that I wanted to get you on the show today is that you wanted to kind of redefine healthy nutrition. And before we kind of get into the real main bit of the interview on that, why is it that we kind of currently need to redefine healthy nutrition?
Well, Sam, I think that from my experience in medical school, the traditional mainstream guidelines, I've come to realize had basically got it wrong. And I'm on the tail end of the baby boomer generation, being born in 1960 rather. The end of the baby boomers were in 1962. And I think my whole life has really gone through this paradigm shift in nutrition. And specifically, as you're aware, in the 1980s, when the U.S. federal guidelines came out, and basically with the hypothesis that saturated fat was bad for us, and that in return we need to reduce saturated fat in the diet and replace it with either polyunsaturated fat and or carbohydrates, that we would effectively address chronic disease. And unfortunately, for several factors, I mean, you might say that the federal guidelines started the wheels rolling, but then the food industry got involved and decided that since the food wasn't palatable, that they had to find ways to make the food palatable, and so they added sugar and further refined and processed these foods, and unfortunately they wreak havoc on our body and only precipitated chronic disease rather than prevent it. And so throughout my medical training, and again, originally from Philadelphia, I trained at Temple University. I'm a very much traditionally trained primary care doctor in family medicine or general practice. And first of all, we didn't learn a whole lot about nutrition, and it took me 10 years in my career to figure out that something was wrong. And about that time in the late 1990s, it's very interesting. I often relate my experience to that of Dr. Eric Westman and also Gary Taubes. We're kind of in the same generation. And in the late 90s, at least for us, there was an awakening to the fact that something was wrong with nutrition. And around this time, I had some experience with both patients, family members, and some personal experience. Sorry, I hit the microphone. Who really presented to me this issue of redefining nutrition in terms of reducing carbohydrates and eating more natural foods containing saturated fat. And like most docs, I said, I'm a little concerned, I'm a little skeptical. You're going to eat all the saturated fat, you're going to drop dead from heart disease. And lo and behold, I was at least open to the idea and followed their metabolic markers, and they improved, and they lost weight, and they felt great. And you know, that light bulb went off in my head, and I started doing my homework, and here we all are now, almost 15 years later, and I have now experience addressing nutrition with our patients. And the fun in our office is that we're trying to blend this traditional approach of medicine, of which I'm trained, and combining it with this more functional approach, the nutritional approach. And the challenge here is not to throw in the towel in healthcare. I think, you know, modern medicine is wonderful, but the idea is how can we blend nutrition into it and redefine the delivery of healthcare? And that's what we're trying to do each and every day.
That's awesome. That's absolutely awesome. And you kind of specialize mostly in kind of type 2 diabetes and metabolic syndrome and treating those, as you say, with kind of traditional measures along with a proper nutritional approach. So say if somebody kind of comes to you with type 2 diabetes and they say, you know, I've just been diagnosed with type 2 diabetes. I heard you're the best doctor in Denver that treats this, Dr. Gerber. And how do you go about treating that?
Well, thank you for the compliment. I wouldn't say I would be the best doctor in Denver. I'm not a diabetologist per se, but I'm somebody who really focuses on nutrition to address prediabetes, insulin resistance. And, you know, the reason I focus on this is because it affects almost 2/3 of our population, and so it's just a natural that I would be focusing on these types of medical conditions. But understand that we have young, healthy individuals such as yourself that are, you know, quite fit and looking to improve exercise performance. So we get all sizes, we get all shapes, we get patients on all kinds of diets, and so. You know, I don't often have the luxury of saying you have to do this exactly this particular way. So we really have to tailor it to the individual, because it turns out that patients that are insulin resistant and are diabetic do best on low-carb, high-fat, ketogenic diets. But then you take other individuals that say don't have as much weight to lose, or they're not as insulin resistant. Well, you address diet with them differently, where still the concept of eating more natural foods, natural fats, saturated fat, but they can tolerate more healthier carbohydrates from vegetables, from fruits, safe starches, those kinds of things, as opposed to, you know, an overtly type 2 diabetic is where your question was getting at. And those people do exceptionally well on the low-carb, high-fat ketogenic diet for the main reason that it really regulates blood sugar, it improves insulin resistance, it reverses diabetes, and it controls appetite. That's the main reason right there.
Mm-hmm. Absolutely, absolutely. So what would kind of somebody's daily diet look like that has got type 2 diabetes and has kind of maybe been following the conventional wisdom of perhaps a high carb, low fat diet, kind of just including whatever sugary foods they want and just take their insulin and metformin and things like that? What should they maybe perhaps try before all of that?
Well, here's the contrast. The American Diabetes Association in our country, the American Academy of Clinical Endocrinologists, do recognize ketogenic diets, but their mainstream guidelines is that a type 2 diabetic should eat a minimum of 40 grams of carbohydrate a meal. So that's a total of 120 grams of carbohydrates a day, and they don't even really specify the type of carbohydrate, and that's basically at the way above what we would ever recommend. And so for type 2 diabetics, the goal is really to get them into a ketogenic state where they would require less than 40 to 50 grams of carbohydrate a day, as defined by Dr. Stephen Finney and Jeff Volak, and that also includes increasing saturated fat up to say 70, 80% or more of calories.
Absolutely. And what would kind of the daily diet look like in terms of the whole foods themselves?
Yeah, so it depends on where you're at. So if we have a diabetic that is, say, a type 2 who's even on insulin, but the pancreas is still working. And it brings up another great point that a lot of the mainstream docs are taught to prescribe insulin way too early when the pancreas is still functioning, and that's really inappropriate. But if the patient's really struggling, has a lot of weight to lose, so we would immediately put them on a very, very high-fat diet. And so this is where Dr. Atkins and I think Finney and Volek are really in the right place. They talk about eating eggs, pastured eggs, the high-quality eggs. You can use Kerrygold butter or coconut oil to cook in, and high-quality bacon and sausage, so that would make a great breakfast. Lunch, perhaps salads, with, of course, the idea, as I tell people that are type 2, that they're always trying to figure how they can add fat to the meals that they're eating. So in the salads, they want to use avocado, guacamole, perhaps some cheese. They can use fatty cuts of meat. We have these fat bombs, or things that people are consuming. Also, bulletproof coffee, which can be either with butter, with coconut oil, with heavy cream. And again, if you are going to eat a lot of dairy, I think it's really important to get a very high-quality form of dairy. I think I'm particularly concerned about hormones and antibiotics that are in kind of these factory farmed environments, and if we're going to be eating a lot of dairy, I think we should pay attention to that. And then let's see, dinner, a protein, a vegetable, and then the idea is that we really want to increase the fat content. So again, to cook those meals in some sort of saturated fat, whatever turns you on. So that would be a typical day initially.
Absolutely. And then when you tell that to somebody that's possibly been following kind of the ADA standard advice, or the Diabetes UK standard advice over here, and then you tell them that, and kind of perhaps their regular GP or their doctor has been telling them all this time that saturated fat is going to give them heart disease and make them perhaps even more overweight and obese. What do you say to them then?
Yeah, right. So that is exactly the typical response. And I have a couple of things to say. Number one is why fuel the fire? It's basically like putting kerosene on top of the fire. If you're insulin resistant or type 2 diabetic, you're so sensitive to dietary carbohydrates. Why should you bother with them? And the other point is to point out the problem with modern medicine and the lack of knowledge in terms of nutrition. So you go to the endocrinologist, and he tells you to cut out the sugar. And you go to the cardiologist, and he tells you to cut out the fat. And then you go to the kidney doctor, and he tells you to cut out the protein. So if that makes any sense, they're telling you to basically stop eating. So yeah, something's wrong there.
Big time. We've got the carbohydrates covered, the fat covered, and the protein. The three macronutrients that we've got to eat, and we're told to eat none of them.
Well, yeah, I mean, honestly, they want us to be undernourished, and we're eating foods that make us hungry all the time. And so there's such a big disconnect. And so this is just part of my awakening over the years. And I must tell you, Sam, that practicing medicine has been only joy over the last 15 years, because although we still treat sick patients, we still have patients on medication, we have patients, unfortunately, that get hospitalized, but we spend a lot of time preventing hospitalization. We spend a lot of time preventing chronic disease. We spend a lot of time taking patients off of medication and treating their health with real food. And it brings joy to my heart, to my patients. My physician assistant, Erin Kay, who you might see running around behind me, is here because she's nutrition-based. And, you know, I've been at this almost 25 years, and I'm still having fun.
That's awesome, and it's really good to hear that you're kind of blending the two of in terms of traditional medicine and kind of this new wave of functional medicine that you kind of sort of alluded to earlier, because it's still important that we still have this traditional medicine here, because you know that's what's partly responsible for us living a lot longer. But then at the same time, perhaps the dietary advice is kind of bringing that lifespan down maybe a little bit, or making the quality of life a little less than it could have been. But if we blend these two correctly, we might end up with average ages and average lifespans of over 100. You never know.
Absolutely, Sam. And it seems like such a natural for us. In fact, we had a young physician assistant student who I had made contact with actually last year, and he made his tour around the country just last week, and he's heading off to physician assistant school in New Mexico. Tim is his name, and just to tell him that he needs to stay the course, and we need young individuals to become healthcare professionals and to basically infiltrate from the inside and bring about change, and to understand that we shouldn't go outside of modern medicine, but bring it into modern medicine and redefine what it is, because you know, healthcare professionals, my experience of course comes from medical school. We spent, you know, a day or two discussing nutrition, and we spent more time learning about medication. It's not a bad thing, but you know, I joke that my medical school and education in a sense was funded by the pharmaceutical industry, and I think you can understand, although I had to pay quite a portion of that out of my own pocket. But yeah, the idea is to just incorporate nutrition into modern medicine, and it's a great way to save money and improve health.
Absolutely, and it seems quite obvious as part of the approach, because there's a fair amount of at least half decent randomized controlled trials out there showing that a low carb, high fat diet of real foods can be just as powerful as any medicine, and it can actually help wean people off of medicines as well. So it seems like this should kind of be the conventional approach to reducing and reversing type 2 diabetes and getting people off of medicines as well.
It's a great point, Sam. So we have many randomized trials out there, but they're short term. So the longest goes about 2 years. I think this Stanford A to Z is one of the best studies that really compare a low carb diet to a low fat diet, and over the 2-year period we see that the metabolic markers improve, but we don't really have any long-term outcome studies that show a benefit or not, comparing a low carb high fat to a low fat low calorie diet. And hopefully groups like NUSI and other groups will actually take an interest, but the problem is it's just so hard to study nutrition, feeding experiments and caging human beings for a period of time. It's almost impossible to do. Now the funny thing is the low fat proponents really don't have any evidence to show that it prevents heart disease. In fact, you know, it's funny, long term we don't really have much evidence that shows anything. We look at these recent meta-analysis in the past in the past couple years that basically looked at nutrition since the 1970s, and they're trying to make an argument that they were trying to prove that saturated fat was bad. And to be honest, what they demonstrated is that it didn't show that saturated fat was good or bad. Because of the nature of the studies, they were just done poorly, or they weren't looking at food quality, or when they eliminated saturated fat, they gave polyunsaturated fat, or they gave sugar. And I mean, some of the studies, like I think it's the one in Australia, the Sydney Heart Protection, did try to make this point that replacing it with polyunsaturated fat that had omega-6 actually worsened heart disease. That there may be some validity to that, but some of these studies, you could say, well, the problem was that you eliminated the saturated fat. The problem was that you gave them sugar, and it kind of neutralized everything. So it's almost like we're at square one. But so far, when you look at well-done experiments, proper experiments, as you mentioned, at least on the short term, you can see the benefits of low-carb, high-fat diets compared to the low-fat diets.
Absolutely. It's quite compelling, because I'm doing this lecture this week at a kind of a fitness professional convention called FitPro Live. One of my lectures is called Why Dietary Fat is Making a Comeback, and I've chosen 15 of the best randomized controlled trials over the past 15 years showing that a low-carb, high-fat diet is better than, say, like a low-fat, calorie-controlled diet. And the one thing that kind of really comes across from all these randomized controlled trials is that when they have the low-fat diets, they're calorie-controlled. But then with the low-carb, high-fat diets, they're ad libitum, or as much as you want diets. And kind of, if you focus on the quality, the quantity kind of tends to sort itself out.
Right, so the question is, can you get any useful information out of studies like that?
Yeah, absolutely.
Right.
So it's not really kind of a fair comparison. And one of the most recent studies that was published in PLOS One back in April was just a short-term 3-month study. It was free living, and it was kind of 24-hour reported dietary data. But what it showed is that people that were on the low-carb, high-fat diet of real foods with an ad libitum diet ended up reducing their calories from, I think it was about 2,500 calories a day to about 1,600 calories a day, without sort of the control sort of saying, reduce your calories. They just kind of did it automatically, and they lost, I think it was about almost 7 kilos in 3 months. But then on the other arm, the low-fat calorie-controlled diet, they took their calories down to 1,200, and they actually only lost 2.5 kilograms. Yeah. So the low-carb, high-fat diet ate slightly more calories and lost more weight, and the low-fat calorie-controlled diet ate less calories and lost a little less weight as well. And it's quite incredible that kind of this isn't getting soaked up or at least sort of looked into even deeper, because this kind of suggests that there's something going on in terms of the biochemistry itself that helps you kind of suppress your appetite, feel satisfied, like you don't have to eat anymore, but at the same time it's also releasing your body fat to be used as energy, perhaps. What are your thoughts on all of that?
So there have been other studies that also have shown that even on with the low carb, high fat arm, that may tend to eat more calories, that they still lose a greater amount of weight, and that just brings in the whole idea that we're dealing with something that's more than energy balance, that there's hormones and there's biology that has to be considered. And so hopefully more research will kind of tease that out. And it's just fascinating. I try to follow it. I'm not a statistician. And I know, there's a lot of great people out there on the internet that have no degrees, and a lot of them, for instance, engineers, and we had come to meet Ivor Cummins, and that's how I'm here today interviewing, because you had just interviewed him, and he's fascinating individual. He just appeared in the last year. He had become interested in nutrition for personal reasons, and now uses his engineering skills to apply it to medical research. So we've become great friends and colleagues, and it's just interesting to hear opinions in both directions. And I also often find it interesting on the internet that it's fun. It might be the nature of the beast, but people want to draw a line in the sand and take a position to the right, to the left. And I always say I don't have that that luxury here in what I do, because I see all kinds of people, and we see people with different genetics, different body types, and we have to kind of sift through all the noise and come up with reasonable advice. But it's fun on the internet just to listen and to respect people's opinions.
Absolutely, absolutely. And there's kind of a varied amount of opinions out there. But one thing that a friend kind of said to me this week is that the two most common words that are said throughout kind of the health and fitness industry, whether it be kind of medical or personal trainers or anything like that, are "it depends." The two most common words that are said by anybody in relation to their advice to someone, because it always depends, doesn't it, in terms of somebody's personal and specific situation. And it's so difficult to give kind of general advice, but currently kind of what the randomized controlled trials are sort of saying is that kind of the best place to possibly start in terms of reversing any kind of metabolic conditions that you have is quite possibly a low-carb, high-fat diet of real foods.
Yeah, so I think a majority of us agree that refined and processed foods are a problem. Sugar is a problem, and fat, even saturated fat, may not be so bad. So I like to look at what we have in common rather than what we don't have in common, and try to go from there. And at least the beauty in what I do is that I get to follow patients, and we can follow metabolic markers, checking them for their hemoglobin A1C or blood sugars or lipid profile, advanced lipid testing. As you know, cholesterol is one of my favorite topics because it ties so much into nutrition. We check inflammatory markers. You can do genetic markers, and we can do a cardiovascular imaging, and the list just goes on and on. So we follow patients carefully. My experience is anecdotal. I'm not a researcher, but I can tell you that over 15 years, I feel that I really have helped a lot of my patients who were diabetic that never had a heart attack in 15 years, patients who are diabetic or had weight issues and maybe had a heart attack and they haven't had recurrent events. So we've had a lot of success stories, but also to point out that for some it's hard to lose weight. We have women that tend to be metabolically normal. In fact, they're more insulin sensitive than anything else, and we call them the weight loss resistant group. And so the challenge is, well, what do you do with those? Well, guess what, Sam? Calories do count.
Yeah.
And, because they don't gain the benefit of being satiated by eating all the saturated fat. In fact, everything satiates them equally. In fact, it puts them at a disadvantage. So we have to think about other things. They don't need to necessarily eat as high in fat diet, although some do and do great. We have to think about the quantity, again, the quality of the food, and sometimes there's medication that can kind of give them a little bump to get the weight loss going. So those are some of the challenges that we deal with.
Absolutely, absolutely. And as I was sort of kind of saying there, it always depends. And, you know, you got to try and really find out as much about someone's specific situation before giving any kind of proper advice there. And sort of, you know, being able to have someone like yourself on hand who's had kind of 15 years experience in terms of sort of treating people along with traditional medicine and this new kind of nutritional approach, and sort of 25 years in terms of your total career in the medical profession is ideal, and people can kind of gather that all of that information and knowledge that you've kind of collected over these past 25 years via your blog, denversdietdoctor.com.
Yeah, so the blog is just an extension of what I do because I realized that the only way to get the word out is through social media. I didn't really think it had any value way back in the late 1990s, but now I've come to realize how important it is and how much fun it is. I think I'm addicted like the rest of us. But the blog is important, and I'm learning every day, Sam. You know, I think what I did a year ago is different than what I do today, is different than what I did 5 or 10 years ago. So you know, I have a steep learning curve. Cholesterol, especially, I don't know if you want to take a minute and talk about what do you do with patients on low-carb diets who have rising cholesterol. I'm sure you've heard about that.
Oh yeah.
Yeah. So it's a bit of a conundrum to try to figure out in these patients that. You know, despite every favorable metabolic marker, in some we see rising cholesterol. And, you know, it makes me think about the genetics of it, that some people absorb cholesterol differently or produce it in the liver or clear it differently. So we have to consider genetic factors. We have to, again, look at the whole concept of cholesterol itself, that if we got this wrong, that maybe cardiovascular disease and atherosclerosis isn't necessarily a disease of cholesterol, but a disease of other factors. We often talk about inflammation and oxidative stress, but again, we have yet to tease this out, so we follow patients carefully. And some patients on low-carb, high-fat diets who have strong family histories, we have to tweak their diet, perhaps switch to monounsaturated fats, consider intermittent fasting, reducing quantity of food, even considering medication, although medication for absolute risk reduction doesn't appear to do a whole lot. But again, your local cardiologist would tell you otherwise. So we're kind of, you know, open to the idea of thinking outside of the box and kind of challenging what we learned.
Absolutely, absolutely. And it's always a learning curve for all of us. And that's kind of one thing that I always want to reiterate to people, is that I don't have a fixed position, and I don't think anybody that is serious about helping people has a fixed position on things. I think we're all willing to kind of listen to new evidence and listen to new ideas and sort of see if we can tease out more about the human body, because we don't know everything about the human body, unfortunately, quite yet, and in terms of how it interacts and how it reacts to different foodstuffs and things like that. So it's a learning curve for all of us. And yeah, it's great to hear a doctor like yourself who's practicing with patients every day that's kind of open to new ideas and looking at the evidence and sort of seeing if it works. And when it works with your patients, you continue to use it. So it's absolutely incredible, Jeff.
Yeah, thank you, Sam. And it's fun. I mean, now I attract clients and patients that are like-minded. And I always joke, so, you know, they come to me so that I can tell them they can stay on these non-traditional diets and they don't have to take their medication. And the question is, still, every day I challenge myself, am I giving them good advice or not. And I just across the board don't tell people to stop medication. We have to take a look at it very carefully.
Absolutely, absolutely, always. And on that note, I'd like us to head over to our friend who we were talking about earlier, Ivor Cummins, and his question via Facebook, which is about vitamin D, and he asks. He's becoming increasingly interested in vitamin D as a deficiency that has very significant implications in the modern population. Could you give your thoughts on low 25 hydroxy D patients that you see and how you deal with it?
Sure. Well, thanks for submitting the question, Ivor, and I hope you're going to do some research and help me with answering some of the question here. But in our office, we like the vitamin D25 level to be between, say, 40 and 60. But it's interesting, Sam. There's a lot of things in medicine that become fad and then not fad in mainstream medicine. And I think vitamin D is important, but maybe for a good reason, vitamin D is becoming kind of fatty in modern medicine. So many of my colleagues, although very mainstream focused, and I love them dearly, have begun to focus on vitamin D because we found out that if you give patients too much vitamin C, it promotes atherosclerosis and all kinds of problems. So wow. They realized that that was a bad recommendation, so now we're shifting over to vitamin D. And just my comment, again, I'm not an expert on it, but I think all the fat-soluble vitamins, particular vitamin A, D, and K2, are just critical and important to diet, and we tend to miss out on those when we avoid perhaps animal products. I always tell patients how important eating the liver, the bone broth, the offal, those kinds of things are just so important in terms of fat-soluble vitamins, minerals, and nutrients, including vitamin D. So again, I hope Ivor, who is just excellent at just perusing through all the literature, will be able to show a link between vitamin D and atherosclerosis and that, osteoporosis, and so forth.
Undoubtedly. And then when he puts up his next lecture, we'll get him back on the show to talk about that, because if people haven't seen this show before, you can check out Ivor Cummins' interview about the cholesterol conundrum. I can't think. The Fat Emperor, that's right. You can check Ivor out at the fatemperor.com. But yeah, that's fantastic, Dr. Gerber. And thank you so much for your time today. And there's only one more thing to do, and that's to hear a smash it out from Dr. Jeffry Gerber. So on 3, I want you to shout "smash it out" to the camera. So 1, 2, 3.
Smash it out.
Yeah, that's what I'm talking about. That's fantastic. So again, thank you so much for your time today, Dr. Gerber. And everybody, make sure that you check out Dr. Gerber's website, blog, and practice at denversdietdoctor.com. And you can check out all of his social networks through there, Facebook and Twitter and everything like that, as well as your YouTube channel as well, Doc. Isn't that right?
Yes. Thank you, Sam.
Perfect. Thank you. Thanks again, Doc, and I'll speak to you soon. Bye.